for everyone for coming to my talk. I'll chat about some challenging cochlear implant cases today. So this is actually one more important and relevant topic because of expanding cochlear implant selection criteria. I think there have been a lot of recent discoveries that have challenged some of the prior absolute contraindications. In fact, there are even cases now of there's evidence of patients without cochlear nerves having at least some auditory pathways running through facial nerves and similar really rare anomalies where these patients previously would be considered not cochlear implant candidates now are. So I guess the pool of congenitally deaf children is increasing, but kids with interim malformations definitely present some unique management and intraoperative challenges. But before going there, I'll just focus a little bit on our favorite topic, which is embryology. And just as a review, the otic placode is going to form from an ectodermal lining around the 3rd week of development. And at the 4th week, it's going to form into the otocyst, which will become ultimately become the membranous labyrinth of the vestibular and the cochlear system. Around the 5th week, it's going to invaginate into 3 separate little folds. So there's the primitive endolymphatic duct and sac. There's the primitive utricle and semicircular canals, and then you have to start the saccule and the cochlea. Around the 6th week of development, the cochlear duct is going to begin spiraling from the basal turn, and around the 8th to 10th week, it's going to complete the full 2.5 turns at the apex. The organ chordae will form around 25 weeks, and again, the kind of the cartilaginous precursor around the membranous labyrinth is going to form into the heart of the capsule bone throughout this development. So it would make sense that any arrest at any point along this embryologic pathway is going to have very predictable outcomes. And this was actually first characterized by Dr. Jackler in 1987, which this image on the right is from. And this was kind of the first real way to describe these based on embryology. Previously, they had a lot of nondescriptive eponyms. And at this point, we would coin terms like the common cavity, Cochlear Genesis, Cochlear Hypoplasia, and incomplete partitions. And despite a number of classification schemes since then, they all generally share the same sort of embryologic basis since then. I won't talk too much about the workup of congenitally deaf children. I'll just touch a little bit on imaging here, mostly to say that CT and MRI are going to be complementary. CT, as we know, is really good for assessing bony anatomy, and we'll pick up osseous abnormalities in about 20% of patients with congenital sensory neural hearing loss, and that proportion is actually going to be higher in patients who ultimately go on to get cochlear implants. MRI is going to be more sensitive to evaluate for cochlear patency and any septations within the cavity. It'll be useful to assess for the cochlear nerve and the presence of it, and it can help identify any other central causes of hearing loss. So just looking at a few images, these don't all show up great, but this is an axial scan of the right ear. You can see that the cochlea and the labyrinth are actually very hard to distinguish from one another. So this is described as like a snowman appearance, and this is pretty classic for the common cavity deformity, suggesting that the arrest here happened sometime in the 4th week of gestation. In this, we can see the IAC in the middle of this axial cut, but then we don't actually see any of the, we don't see patent labyrinth anywhere. So this looks like labyrinthine aplasia, but if you actually notice, the otic capsule has formed and it's just ossified. So that's not what labyrinthine aplasia looks like. This is labyrinthine aplasia on this coronal cut, where there's actually no development whatsoever of the otic capsule or the middle ear structure. Sorry, the inner ear structures. This is a coronal cut showing an example of cochlear hypoplasia. The key here is really just the height of the cochlea itself. It is very short. This can be evidenced by the distance between the cochlea and the facial nerve here. Here is an example of an incomplete partition. So the cochlea has formed, but there is not a complete septation in it. And this is most commonly going to be associated with an enlarged vestibular aqueduct. You can see normal caliber here on the patient's right side, and on the patient's left side there is a very large aqueduct. MRI is useful, as I said, to identify the nerve. These are fiesta sequences that help identify a really kind of diminutive eighth nerve here in the cerebellopontine cistern, but you can actually barely see it when you go out a little more laterally in the IAC. And here in this sagittal oblique cut, you actually don't even really see the nerve. You can barely make it out in the anterior inferior location where you would normally expect to find it. With that said, a lot of these patients with congenital inner ear malformation actually do have pretty variable and sometimes decent pre-operative hearing. In fact, some patients with common cavity deformities can even have very mild or moderate hearing loss, while others will have very profound hearing loss. And this is unsurprisingly due to a great variety of spiral ganglion counts in these patients. Some will have, a normal cochlea will have somewhere between 25 and 35,000, while some malformed ears range anywhere from about 1/5 to 1/2 of that. So looking at how these kids actually do, there was a really good study out of the Hospital for Sick Children in Toronto, where they looked at their results for about 300 patients over a 10-year period. And about 1/3 of those kids had various cochlear vestibular anomalies, including some common cavities, hypoplastic cochleas, a lot of incomplete partitions, and some large vestibular aqueducts. What they found was that actually the most common middle ear abnormality was an anteriorly displaced facial nerve in about 15% of those patients. Although luckily none of those patients had postoperative weakness, the most common complication was a CSF leak, but I'll come back to that. So just looking at abnormal facial nerves, so as I said, about 15% of their patients, their series is shown down here. So it's only 15%, but in the hypoplastic cochlea cohort, it was almost 50%. And it was about 25 to 30% of the common cavity deformities. And that's pretty consistent with some smaller series that previously published. Here's an intraoperative picture from that study. This is the left ear. This is mislabeled. This is actually the 7th nerve. You can see through the facial recess here, the posterior branch of the facial nerve is where it's normal, where we'd normally expect to find it. And there's an early abnormal branch, or anterior branch right here that's actually going over the promontory. It's obscuring the oval window and making it very difficult to visualize the round window in this patient. Other anomalies you might find, this is an axial cut of a 5-year-old with a hypoplastic cochlea. There's a very prominent sinus pericardia there. And you notice here there's also an anteriorly displaced facial nerve, so the trajectory here to reach the facial recess is actually very narrow. So having this information beforehand, the surgeons planned the canal wall down approach with the subtotal petrosectomy. As I said, CSF leaks are going to be the most common complication you're going to see in congenital malformations. It's generally thought to be due to an abnormal communication between the cochlea and the subarachnoid space, and definitely going to have increased rates in these children. Management of an intraoperative CSF leak would be to actually drain off some of the fluid just to reduce the pressure, taking very good care not to get any air into the labyrinth. Packing of the cochleostomy site to make sure that it's not continuing to leak. A lumbar drain can be placed in cases where with persistent leak, and of course in recalcitrant cases the ear can be closed. Gushers are definitely more common in enlarged vestibular aqueducts just because that's a more common deformity, but the rates are actually higher in other congenital malformations. So from that same paper, you can see their series here of 103. They only had 7 CSF leaks, but it was almost 50% in the common cavity deformities, more common in hypoplastic cochleas, and it was only 1 out of 37 large vestibular aqueducts. And again, those numbers are pretty consistent throughout the literature. That same paper, when looking at how these kids do both open set and closed set performance, the bottom line is across all these anomalies, all patients did better post-operatively after implantation. The patients that did the best were going to be those with normal anatomy, the 200 that they did, and the patients with incomplete partitions. What they found was that the best predictor of post-operative speech performance was actually pre-operative speech performance. And not surprisingly, that is actually, generally speaking, correlates well with age and correlates with slower progression of hearing loss. And so if you consider normal, kids with normal anatomy and kids with incomplete partitions are generally going to be the kids who present older and, again, have better preoperative speech performance. So just looking at those incomplete partitions and comparing them with normal kids, this was a smaller series in another study that matched these patients to normal pairs. And again, they found no significant difference between normal anatomy and the incomplete partition patients. The normal kids were in the gray, and the partitions were the black lines over there. Cochlear Hypoplasia is definitely rare. There isn't a lot of data on their outcomes, but this is a pretty large study of about 450 patients out of South Korea, which included 2 patients with Cochlear Hypoplasia. Those kids were selected for implantation based on evidence of an nerve on MRI, and both of them were found to have electric compound potentials and brainstem stimulation on steady-state electrical testing, which is similar to an ADR test. So both kids were implanted, one through the open window and another just through a transmascular labyrinthotomy, and both actually did very well with hearing thresholds at 25 decibels, and they both achieved open set speech perception. We'll just turn our attention quickly to post-meningitic deafness. In this case, a 7-year-old male who presents with bacterial meningitis after ear infection. He was actually in the ICU. He was attended, intubated for a few days, and then he ultimately grew up and he told his parents, "Something's wrong, I can't hear you," and he was very dizzy. His lumbar puncture grew strep pneumo. The rest of his history was pretty unremarkable. His exam was pretty normal, except his audiologic assessment was grossly abnormal, which was confirmed by his audiogram that showed bilateral profound hearing loss and basically 0% performance speech testing. His imaging on the CT, you can see that there's actually increased density in the inner ear structures here. It's more pronounced on the left side. And his MRI, you can see that there's actually a loss of the kind of intracochlear fluid signal on the left side, again more pronounced on the right side. Just quickly looking at bacterial meningitis, it is actually the most common cause of postnatal profound hearing loss. It is generally caused, or thought to be caused by actual purulent exudative damage and inflammatory insult to the inner ear after either bacteria or inflammatory cytokines traverses a patent cochlear aqueduct, which will usually terminates at the basal term of the cochlea. Most common causative agent is going to be strep pneumo, and there's about a 10% incidence of hearing loss after bacterial meningitis. Of those patients, 50 to 70%, depending on where you look, are going to have bilateral hearing loss. So after the initial sort of the immediate inflammatory stage, you're going to have like a delayed fibrosis stage, which can occur as early as 2 weeks after meningitis. But some animal model shows might begin actually 72 hours after the initial insult. And that's going to be followed by ossification, which can directly destroy the spiral ganglion cells and can occur as little as just a few weeks after the infection. But in some cases, it can actually develop many, many months later. So normally, you expect to have the lumen of the otic capsule maintained, but with new disorganized bone being formed and replacing healthy bone, you can get labyrinthitis ossificans, which is the pathologic state of either partial or complete obliteration of the cochlear lumen. It can occur in about 90% of patients with hearing loss, at least to some degree. This is a H&E stain, so it's actually showing the basal term, which is usually where it starts, just because where the cochlear aqueduct is going to originate. You can see a little open lumen of the sinus tympani here, some fibrotic changes, some osteoid deposition, and then some frank ossification right here. This is normal bone of the otic capsule. So management of these patients can be challenging because obviously stabilization from their infection takes primacy. After that, early and serial audiologic evaluation and immediate amplification is really important. But any deterioration clinically or on their audiogram should prompt at least consideration of cochlear implantation. But it's usually going to reflect progressive fibrosis and ossification, and generally speaking, these patients are going to be progressively worse. As far as imaging goes, again, MR and CT are going to be complementary. As we know, CT is going to show us osseous anatomy, but it can underestimate the true degree of ossification in about 50% of cases. T1 post-contrast images will show early areas of fibrosis or areas of concern, while the T2 weighted imaging can show attenuation in intracochlear fluids, just as we saw on this child's scan. MRI probably is the gold standard, though. You have to pick one because it can predict the intraoperative it can predict cochlear obstruction with a high degree of sensitivity and specificity, but the true degree of the actual cochlear obliteration is really not evident until you get into the OR. Then basically every study shows the same thing. There are a number of different grading systems. You can take your pick. This is just one. Grade 0 is a normal ear. Grade 2, there's a little fibrosis, but no true luminal narrowing. Grade 2, there's diffuse fibrosis and some narrowing. And on the scale, grade 3 is complete luminal obliteration. Generally speaking, if the entire cochlea is obliterated, that is an indication for an auditory brainstem implant. But for the most part, other kids at least can be considered candidates for cochlear implantation. And so just like with any other cochlear implant, our goal is to have full electrode insertion within the scala tympani. But sometimes that's not possible. So if there's just a little bit of fibrosis at the round window, again, that's usually where fibrosis can begin after meningitis. You can just, through a normal facial recess, drill out the round window and access to cochleostomy. You can even drill out portions of the basal turn. So this is a left ear. This is actually a prior canal wall down cavity, and you can see the area where the round window should be. This looks blocked, but ultimately when you drill, you'll see a thick, chalky deposition there, but ultimately you should be able to reach the lumen. There are cases, again, where more extensive areas of the basal turn are going to be ossified, which can necessitate more of a drill out. This can usually be accomplished by, an extended posterior tympanotomy or an extended facial recess, where you take down the incus and take down the buttress to get a little bit more access. So in this right ear, you can see the round window overhang right here, which has been drilled away, and you can kind of pick into the lumen, but again, it's very narrow and fibrotic.
It's quite an extended facial recess.
Yes, indeed. Ultimately, though, if the entire scala tympani is obliterated, we have any evidence of that, scala vestibuli insertion is an option. This generally is going to require more drilling. You're going to have fewer landmarks, and both of those can increase risk for damage to the basal membrane. You'll have, after implantation, there will be a larger distance between the actual electrodes and the intracochlear neural tissue, which can require higher electrical stimulation levels. So that could lead to, again, facial nerve stimulation or other issues, and can be a challenge when programming. And at least theoretically, a larger opening into the, or an additional opening into the cochlea can increase the risk of meningitis, but this has mostly been obviated by the vaccination. Anytime you're drilling not in the round window or you're going deep or extending into the basal turn, you do have to be careful, anteriorly, just to not injure the intracranial carotid artery. And drilling is usually, again, done in an anterior and inferior direction, so again, you don't injure or damage the dilus or the basal membrane. This is just a schematic showing, again, the incus and stapes have been removed. It's just showing that target for scala vestibuli cochleostomy through the cochlear-form process of the stapes foot pipes. If the entire basal turn, both scala vestibuli and scala tympani, are obliterated, middle turn cochleostomy is an option. I didn't have any intraoperative pictures, but this is from the right ear of a cadaver showing, so this is a double array insertion through both a round window basal turn drill-out and the middle turn cochleostomy. Here's an example of a retrograde insertion through a middle turn cochleostomy that then enters the basal turn. And this is a single middle turn cochleostomy with both a retrograde and an anterograde insertion. So how do these kids do after cochlear implantation? So this is a study out of Brazil that looked at 26 post-meningitic deaf kids and compared them to 26 controls. When they were matched for age, time of deafness, and the implant duration, they found there was no difference in at least the number of active electrodes or the sound field threshold. So they could hear sound just as well. But when they went to do speech testing, they found that the cochlear implantees with post-meningitic deafness did worse across the board, and there was greater variability in all of those children. This speech perception testing, they actually excluded kids with sound field thresholds over 40 decibels, which was a much higher percentage of the post-meningitic deaf kids. So the true numbers actually skewed much further than this. Just looking at ossified patients, this is a study out of Germany of about 90 adults and 30 children with post-meningitic deafness, and they looked at CT and intraoperative findings. What they found was that the presence of ossification intraoperatively was statistically significantly related to the duration of deafness. So the longer you're deaf after meningitis, the more likely you are to have ossification. and they found a correlation between the rate of ossification and the duration of deafness. And this correlated very strongly with the actual electrode depth insertion. So that's important to keep in mind when we look at this study out of the Netherlands of 25 kids with post-meningitic deafness, and they grouped them and compared them by partial electrode insertion and complete electrode insertion. And for the control group with complete insertion, they broke them up by greater than 3 years and less than 3 years of deafness. And just this top graph here shows that the partial insertion group and the full insertion group, there was no difference in sound field thresholds either preoperatively or postoperatively. So, and their ability to hear sound was generally the same, but on speech perception testing, which they did a battery of like 9 tests, and they came out with this equivalent hearing score, lower scores or better, and they found that the partial insertion kids, which is this top line, it took much longer to get any real benefit, and then they sort of plateaued this very high rate, while the complete insertion children generally do much better, and those with duration of deafness less than 3 years do significantly better across the board. So again, all of this really just does give more and more evidence that early implantation or early evaluation is probably the way to go for these kids. We talked about Scala vestibuli insertion. This is, again, it's not that common, but this is a small study out of New York Medical School. Looked at just 8 kids, and again, or 8 patients. Generally speaking, they found that all patients had improvements in communication despite varying degrees of ossification. And again, as I said across the board, preoperative CT did not really correlate well with postoperative ossification. I just did one quick look at the role of steroids in preventing ossification. This is a small retrospective analysis where they looked at patients presenting after bacterial meningitis with deafness, and they either gave steroids or didn't, or they looked at patients who either received steroids and didn't. Their conclusion was that because 4 out of 4 patients who did not get steroids developed labyrinthitis ossificans, and only 1 of the 6 patients that did receive steroids ossified, their conclusion was that steroids do play a role. If you actually look at the data, and it's a limited sample size, but all the patients that did not develop ossification, they were all implanted basically within a year of presentation, while all the patients who did ossify, the average time of implantation was like 42 months or so. So I think the time, again, has much more to do with steroids. So going back to our patient, so he actually had a left cochlear implant, but again, it was significantly ossified. The basal turn Dril-out was performed, but his postoperative CT showed that the electrode actually terminated in the vestibule and was not a complete insertion. So he went back for a revision. This was the old electrode array that was removed, and here you can see the facial recesses that doesn't really show well in 2 dimensions, but this is a depth gauge that's kind of probing the basal turn here, and you can see it's meeting resistance deep there and kind of curling back over itself. So it did necessitate additional basal turn Dril-out there. But even after probing, we couldn't really pass it past the ascending turn of the basal turn, the ascending portion of the basal turn. So middle turn cochleostomy was also performed up here, ultimately allowing for a multi-array insertion both here through the round window and then up there through the middle turn cochleostomy. This is his audiogram at 1 month post-op. He's doing quite well, and he should hopefully return at the second side done. Last topic I'll cover tonight is otosclerosis. The case of an 58-year-old male with bilateral hearing loss, which has been long-standing. He had a right stapedectomy in 1977 with very short-lived improvement, but he did undergo a revision in 1979, and he did pretty well for a number of years. But he comes to us now and he says over the past 20 years he's had no benefit from his hearing aids on the right side, and he only wears a hearing aid on the left side. So, got a long family history of otosclerosis. The rest of his history and exam are pretty unremarkable. Here on his audiogram we see that the right side there's profound deafness. He has no speech perception. On the left side there's severe mixed hearing loss with very poor word recognition. He scores about 24% with amplification. His imaging showed pretty diffuse otic capsule, pretty diffuse retrofenestral otospongiosis on both the left and the right. Just as a quick review, otosclerosis is an osteodystrophy that affects the bone of the otic capsule. This bone is normally free of both osteoblastic and osteoplastic phenomenon. But in these cases, a continuous process of osteolysis and osteogenesis can lead to vascular proliferation, bony resorption, and the formation of new connective tissue that can cause hearing loss. So again, the most commonly involved area is going to be the fistula and fenestra. And once it actually reaches the foot plate, it will develop a conductive hearing loss. And about 10% of patients with otosclerosis, after enough time, they will develop sensory neural hearing loss. And this is generally thought to be due to like ionic perturbations in the perilymph due to involvement of the lateral wall endosteum that causes, when it gets involved with the stria vascularis, it can again cause ionic perturbations. Again, there are a number of different grading systems. This is just one that is proposed, but grade 1 is just it's just solely sort of fenestral involvement. Grade 2 would be retrofenestral involvement of this like double ring or halo sign, and grade 3 would be just diffuse confluent involvement. So far, advanced otosclerosis was a clinical diagnosis first described by Dr. House and Shi in 1961. It involves otosclerosis, an air conduction threshold above 85%, and an absence of measurable total conduction threshold. More recently, there have been some suggestions that speech reception threshold decreases should be involved for a true definition. So in our patient, a few things to consider. So he does have a treatable mixed hearing loss on the left side. That's his only functioning ear. So surgery on that side certainly risks further or complete hearing loss. We generally do prefer to operate on the worst hearing ear, but he hasn't really used that ear for 20 years, so we don't really know how he's going to do after it. Again, there are a number of algorithms that have been proposed, and this patient with this speech discrimination where it is, he could actually be considered a cochlear implant candidate on both sides, but he ultimately elected to go to the operating room for a right-sided cochlear implant. He did have obliterated otosclerosis, which required round window and partial basal turn Dril-out that he was successfully implanted. Just briefly looking at how these patients do, generally speaking, our otosclerotic patients do quite well. So this was a retrospective review of 239 patients with bilateral hearing loss. 22 of them had otosclerosis, and when they matched them for similar age and duration of deafness to the non-otosclerosis patients, they found there was no difference in or the frequency of complete insertions, facial nerve stimulation, reimplantation rates, or ear tone averages. And across the battery of speech perception testing, again, we found no difference well over a year out. Again, this is just showing a number of different validated subjective outcome measures. And again, patients did just as well as those with otosclerosis. This was a similar study looking at 35 patients with far advanced otosclerosis compared to controls. They tried to break it down a little more and do some more subtype analyses, but generally speaking, they found no difference in ear tone averages, speech perception thresholds, or vasollatic bird recognition scores. They did find that the otosclerosis patients did have some lower scores on the monosyllabic word testing ear, but that was more pronounced in patients who had a prior stability or patients with retrofenestral extension on CT. Last study I'll look at here is just, this was looking more at ossification, so in about 38 cases in this series, found about 23 patients had some form of cochlear ossification. 60% was just around window, and about 40% was either complete or partial basal turn involvement. All patients were able to be inserted. One required a scaled vestibuli insertion, and 2 had only partial insertions. But again, across the board, every patient did better. What this showed was that the patients without ossification tended to do a little bit better, but the differences were not statistically significant across all the measures they looked at. So again, any study you look at over the last several decades shows that patients with otosclerosis who were implanted generally do improve, any way you want to look at it. But in areas where cochlear implantation may be not as readily available or resources are limited, this study out of France looked at patients with far advanced otosclerosis, and they compared the primary stapedectomy or stapedotomy group with the primary cochlear implant group. They did find that the primary cochlear implant group did better, but the primary stapedotomy patients, there was a wide range of results. The average word recognition score post-op was here at 50, but about 60% of their patients did so well and did far outclass the average that they didn't need any other intervention. Of the patients that ultimately had a secondary cochlear implant, there was really no difference in their outcomes compared to the primary CI patients. In conclusion, cochlear vestibular malformations are certainly, they can be, but they don't always have to be absolute contraindications to cochlear implantation. The use of imaging is very valuable to fix surgical difficulties, and one should always be prepared to manage any potential complications. Early evaluation and implantation of post-meningitic patients is definitely going to lead to better outcomes. And while imaging is valuable, the true degree of ossification is really only evident in the OR. And cochlear implantation is definitely a viable option for patients with far advanced otosclerosis and generally has good results. And with that, I will take any questions.
Is the Hoover Tower a partial insertion? That's really stubby. So you presented a patient who had far advanced otosclerosis on one side. On the other side was deaf many years after a stapes surgery, and you implanted the deaf side. The question is, if that patient did well on the implanted side, would you consider doing a far advanced otosclerosis type stapedectomy on the other side?
It's certainly an option. I mean, he's not 24% word recognition on the left side. He wasn't doing fairly well, so he meets.
What was his open set on the right side post-implant, or is it too early?
I don't know.
I'd have to go back and look.
But that's, yeah, it certainly gives you a lot more options to deal with that formerly better hearing ear if you can make the right side usable, right?
Yeah.
And it's always, it's a question for patients. We've had a number of patients like that over the years where you can give them some hearing in their formerly useless ear, and then they have some latitude to gamble with their better ear. But yeah, I mean, if he's doing well enough with that right side, we could do a stapedotomy and see how he does, and understands that if he loses his hearing on that side, we could implant that side as well.
To follow up there, one of the things, that word rec score you reported is probably again coming through your introduction. One thing that I think I are fond of doing in patients that do have some degree of a cochlear reserve, we try to do special bone oscillator in those patients. Because if you get a big jump, that would suggest that if you can close that air bone gap, that they could probably benefit quite a bit from amplification. But if they're, speech understanding still remains pretty poor in those situations, then that kind of tends us to lean a little more towards saying, let's go ahead and implant at that point.
That's an excellent point. I was just going to actually say that I've had some good luck with some patients like this with a bone conduction implant. Even the audiogram sometimes is misleading, as Matt was suggesting. I had a 97-year-old patient just recently. I don't know which was the resident was involved with me recently. Was referred to me for cochlear implantation with advanced cochlear otosclerosis, bilateral. And I did a tuning fork, and he could actually hear the bone conduction on a tuning fork, even though the audiogram was off the chart on both sides. So we put a bone conduction implant on him under local anesthesia, and that guy's been a happy bird for at least a year and a half now.
Show us 10-year follow-up.
Yes, I know. But we'll work on it. But so I think this is a very good point you brought up, Matt. You have to really take that audiogram with a grain of salt.
The other thing, to follow up there, it's the percent correct is one thing, but I think what you really have to pay attention to, what level was that signal presented at, and was it with the hearing aid without it? Because the fastest way to have somebody score like crap on one of these things is if they can't hear you. And so that's so if you can maximize audibility in some capacity, then see where they're at, that gives you a bit of information we can work from as well.
Yeah. And it raises the question, you have to be very cautious about interpreting the bone line in a setting like this because of the very firm fenestral closure, and that in fact the actual cochlear function could be better than that. It's sort of a super Carhart's notch, if you will. So just for the residents, when you think about putting the ear at risk with stapes surgery, which has a risk of adverse outcome, a small one, but a real one, generally speaking, we're saying, okay, if we can operate to make it so that you don't need a hearing aid, that's worth doing. We don't generally operate on someone with a mid-level mixed loss who, even if you made them better, would still need a hearing aid. why take the surgical risk if someone's going to have a hearing aid volume set on 5 as opposed to 8, right? It doesn't make any sense. However, I will say, patients like this are some of the happiest people you'll ever meet post-op. They really do well. I mean, it takes them from being unaidable to being aidable, right? And often the word recognition goes up, the bone conduction goes up because you've restored the inertial component of bone conduction, right?
So right here, you got that 24% word rec, that's 105 dB. So basically, you're coming in right here. So this entirety of the speech signal is completely inaudible. So of course at 24%, So the question, if you can get to the point where some of this signal becomes audible again, then they might improve quite a bit. So.
Yeah, but I would agree. I mean, he's wearing a left hearing aid now, right? At the start. Yeah. I mean, you certainly wouldn't operate on that for primal. But if you can make the right ear the better ear, you then have that rule of thumb. Yeah, then you can do the left.
And if you operate successfully on the right side and he gets a benefit, he's still going to get a lot more out of his left ear to help his right ear than he'd get out of his right ear to help his left ear. You know what I mean? So that second ear, or his better ear, even if you don't do anything to that, is still going to give him some significant benefit for his cochlear implant use on the right side.
So
Try BCI on that left side. He may actually hear really good to the bone conduction. The new bone conduction that is coming out is rated now at 60 decibel. So 55, 60 decibel bone conduction, the BCI can still work.
wow. How is his power consumption?
So, well, it's the same
You're talking about the
675 battery. The new Oticon Ponto 4 that's coming
Ponto.
is 60 dB. So this is really interesting.
Great. One quick question. You mentioned in otosclerosis the data didn't show an increased risk of facial nerve cross-stimulation, but it flashed by quickly, but I thought the data actually showed it did. That's certainly been something talked about for a long time because of you lose the dielectric of the cochlear wall, right? It's soft and it conducts through the facial nerve.
Yeah.
Was that, I
These
thought I saw an
studies,
18%.
Generally speaking, with reprogramming though, they were able to bring it all down. This
I
study
see.
actually looked at it. I think it was a 7%.
So remediating it by taking out the offending electrodes is different than saying there's no facial nerve stimulation.
I think
8.6% in symptomatology in the far advanced cases, but the other patients, it was something like 5%, but and they didn't find a statistically significant difference. And one of the far advanced otosclerosis patients was explanted in the series, but
yeah, I think we do see it more, and I think that the audiologists are able to map so that it's no longer an issue that keeps them from using it. So I think that is less of a concern, at least for the surgeons. It's more of a concern for the audiologists.
I take, so that top panel, I take with a grain of salt. It's great that that they're able to, that implies that they're always in mapping. I could probably give somebody thresholds about 0 to VHL if I want. They might not like it, but you can get people to hearing a lot of it. It's not it's literally a matter of how much current you're providing and where you're setting the minimum stimulation level. And so people ideally tend to want to come in at 30, but just because you're down there doesn't mean, that's not something you say, well, with this one group, with one surgical approach versus another. To me, I find that less compelling than I do looking at the speech scores, because I can make somebody draw whatever I want, by setting the stimulation a certain way.
So on the malformations, if the medialis is very deficient or there are very large empty cavities, the penetration of the IC is possible, right? And you showed one case where it was a very limited, this was an ossification, where you had the image after and take the patient back. Intraoperative imaging, is it helpful at all? I know, we're looking in an era where CT scans, certainly in 500 PORs that are opening later this year, there'll be an MRI scan that's there, which will not be useful in this setting, but might be useful in others. Would an intraoperative CT, in difficult cases, perhaps be useful? Yeah.
Yeah, I think so. We get intraoperative x-rays, plain films, whenever there's a question. If you get a CSF leak in a malformed ear, or even if you don't, we'll often get an intraoperative x-ray to make sure we
Just
see
a plain
this
film.
and not this.
Yeah.
Right? Yeah, and that can make a difference. And there are lots of different techniques to try to keep a an electrode array inside of a cochlea when you know that there's a wide connection to the IAC. So that can be a challenge, but it's nice to know before you leave the operating room that it's not in the IAC.
Impedances, intraoperative NRTs don't really show. You could be not really
Yeah,
replacing, but still getting it.
yeah, your impedances are going to be the same, and you know if you're close to a myelinated nerve, you know it's gonna fire, and so your NRTs or NRIs are gonna or ARTs are gonna look the same. Yeah.
Well done.
Yeah, great job.